Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Capecitabine and oxaliplatin in the preoperative multimodality treatment of rectal cancer, surgical endpoints from NSABP R04 by Michael O'Connell et al. My name is Rebecca McSad, and I'm an attending physician at Beth Israel Deaconess Medical Center and an assistant professor at Harvard Medical School in Boston, Massachusetts. My oncologic specialty is gastrointestinal malignancies. In contrast to the experience with colon cancer, local control remains a significant problem for patients with locally advanced rectal cancer. Neoadjuvant therapy became the new standard for T3 and T4 rectal tumors when the German rectal cancer study by Sauer et al., published in 2004, established that fluorouracil 5-FU-based chemoradiation significantly decreased pelvic relapse rate compared to post-operative chemoradiotherapy, even after 11 years of follow-up. Unfortunately, disease-free survival and overall survival were not improved by neoadjuvant therapy in this study. Many approaches have been explored to improve upon these results, and there's ongoing debate about the optimal neoadjuvant regimen for rectal cancer. Under active investigation in the neoadjuvant setting is the role of radiation, the optimal radiation fractionation course, long versus short, the ideal timing of surgery after neoadjuvant therapy, immediate versus delayed, and the most effective chemotherapy regimen. The National Surgical Adjuvant Breast and Bowel Project, NSABP, Protocol R04, the prospective randomized controlled trial discussed in this podcast, evaluates 4 different neoadjuvant chemotherapy regimens administered concurrently with radiation. The context in which the NSABP R04 results are now interpreted differ from the setting in which the study was designed. In the mid-1990s, continuous infusion 5-FU was shown to be a superior radiosensitizer compared to bolus 5-FU for adjuvant rectal cancer treatment. However, continuous infusion 5-FU incurs the risks associated with placement of the required central venous exit, and the pump may be a burden for patients. Therefore, other potential radiosensitizing agents such as capecitabine were explored. Capecitabine is a fluorinated pyrimidine prodrug that offers sustained drug exposure through twice-daily dosing and has the convenience of an oral agent. In the early 2000s, capecitabine was shown to be non-inferior to continuous infusion 5-FU for metastatic colon cancer, and there was increasing preclinical and clinical evidence for capecitabine as a radiosensitizer. Given these findings, the NSABP set out to prospectively evaluate replacement of continuous infusion 5-FU with capecitabine for rectal cancer neoadjuvant chemoradiation. As originally designed, the NSABP R04 study randomized patients to either continuous infusion 5-FU or to capecitabine as a radiosensitizing agent. The protocol required surgery to be performed within 6 to 8 weeks after completion of the 5-week radiation course and boost. The R04 study was activated in 2004, about the time that oxaliplatin was shown to be effective for colon cancer in the metastatic and adjuvant settings. 15 months into study accrual, the study was amended to randomize subjects to one of 2 5-FU agents as monotherapy or in combination with oxaliplatin. This change to a 2x2 factorial design allows comparisons of the 2 5-FU agents with and without oxaliplatin. In addition, this amendment decreased 5-FU dosing from 7 to 5 days a week. Over 6 years, a total of 1,608 patients enrolled on the study. The current report evaluates the impact of the 4 neoadjuvant chemoradiation regimens on surgical and pathologic outcomes, all of which are secondary endpoints: pathologic complete response, PCR, sphincter-sparing surgery, and surgical downstaging. Since the initiation of RO4, results from multiple other studies have evaluated the role of capecitabine and of oxaliplatin for rectal cancer neoadjuvant chemoradiation. A Korean trial of capecitabine-based preoperative versus postoperative chemoradiation did not find the local recurrence benefit for neoadjuvant therapy identified in the larger 2004 German study using infusional 5-FU. However, a subsequent randomized open-label German study published in 2012 found that the 5-year survival for neoadjuvant capecitabine-based chemoradiation was not inferior to infusional 5-FU-based chemoradiation. Although both 5-FU agents had similar local recurrence rates in this study, the capecitabine group developed fewer distant metastasis. The NSABP RO4 results now confirm the equivalence of capecitabine in continuous infusion 5-FU-based neoadjuvant chemoradiation for pathologic and surgical endpoints in rectal cancer. The primary endpoint for the NSABP RO4 study, time from randomization to local regional failure, was presented in abstract form in January 2014. The preliminary data suggested equivalent local regional control, LRC, disease-free survival, DFS, and overall survival, OS, for both 5-FU agents. The full peer-reviewed report is awaited. The addition of oxaliplatin to a 5-FU neoadjuvant chemoradiation rectal cancer treatment, as studied in NSABP RO4, has also been evaluated in 4 other large trials in which more than 3,000 patients have participated. The Italian STAR-01 and the CAO-ARO-AIO-04 trials added oxaliplatin to continuous infusion 5-FU.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.
Neoadjuvant chemoradiation, similar to the RO4 approach. Unfortunately, oxaliplatin repeatedly failed to add meaningful benefit for pathologic, surgical, or overall survival endpoints, and was associated with increased toxicity. Thus, it is no surprise that the NSABP RO4 study also found that oxaliplatin did not improve surgical or pathologic outcomes, but did add toxicity. The 2014 abstract presentation of the local regional control, disease-free survival, and overall survival preliminary results for the study also suggested a lack of benefit for oxaliplatin. Results of the NSABP RO4 and similar studies evaluating oxaliplatin for rectal cancer neoadjuvant therapy raise concerns about the utility and appropriateness of multiple large trials addressing the same question, a subject that has been discussed in prior editorials and commentaries. More innovative trial designs coordinated across research sponsors may more effectively move the field forward for the benefit of patients. The focus of the NSABP RO4 on the non-inferiority of oral capecitabine compared to infusional 5-FU points to the desire of the oncology community to find chemotherapy agents that are less cumbersome for patients and providers. A 2000 randomized crossover trial by Borner et al. Comparing patient preference for an oral fluoropyrimidine regimen taken at home versus intravenous bolus 5-FU given in clinic found that advanced colorectal cancer patients preferred oral chemotherapy. However, a larger 2006 study by Pfeiffer et al. Using the same crossover oral versus intravenous 5-FU design found that patients preferred the regimen with less toxicity. In this case, bolus 5-FU was preferred over capecitabine. In the NSABP-R04 study, the percentage of patients with any toxicity was higher in the capecitabine arm than in the continuous infusion 5-FU arm when patients were dosed 7 days a week. Although overall toxicity was similar in both 5-FU monotherapy arms when dosing was decreased to 5 days a week, the capecitabine arm still had more grade 3 to 5 toxicities, 30.1% versus 26.5%. Thus, it is not clear that patients would necessarily prefer oral capecitabine to continuous infusion 5-FU, given the trade-off between convenience and potential toxicity. In addition, a study by Liu et al. Indicated that patients who prefer oral chemotherapy are not willing to sacrifice efficacy for convenience. The primary issue that may negatively impact capecitabine efficacy is compliance with dosing outside of the closely monitored setting of a clinical trial. Electronic monitoring and survey studies suggest that only 76 to 90% of patients are adherent to capecitabine dosing. Several studies of capecitabine have shown that plasma concentrations can be affected by timing around meals and are related to toxicity and to efficacy. In addition to human error and forgetfulness, non-adherent patients may self-titrate capecitabine exposure to limit side effects. Therefore, it is important to assess which 5-FU experience individual patients favor and to determine if the equivalent effectiveness seen in this randomized trial translates to equivalent efficacy. An ongoing study in the Netherlands of standard of care capecitabine seeks to better understand the relationship between the patient attitudes and experience, attitudes, toxicities, and pharmacokinetics. While the NSABP-R04 provides important data that oral capecitabine is as effective as intravenous 5-FU, it is unclear which agent will be optimal for patients in the real world. Finally, insurance coverage patterns for outpatient drugs in the United States mean that the cost of capecitabine may be prohibitively expensive for some patients. An economic analysis by Cassidy et al. At the National Institute for Health and Clinical Excellence in the United Kingdom favors capecitabine over intravenous 5-FU for adjuvant colon cancer therapy from the societal perspective, largely due to differences in medical resource utilization and in patient travel and time costs. A similar analysis for neoadjuvant rectal cancer chemoradiation may yield different results because patients already have to travel for daily radiation. In summary, the NSABP-R04 study demonstrates that capecitabine given during rectal cancer neoadjuvant chemoradiation yields the same surgical and pathologic outcomes as continuous infusion 5-FU. Unfortunately, the addition of oxaliplatin does not offer benefit and increases toxicity. This trial supports the use of neoadjuvant capecitabine monotherapy as a potentially more convenient radiosensitizer that does not sacrifice surgical and pathologic outcomes in rectal cancer. However, further study on real-world efficacy, patient adherence, patient preferences, and economic implications is needed before routine recommendation for a particular form of 5-FU neoadjuvant radiosensitizer is possible in rectal cancer. This concludes this JCO podcast. Thank you for listening.